Hello and welcome. Welcome to our British Heart Rhythm Society webinar on Friday afternoon. Happy Friday, everyone. Thank you so much for the BHRS for inviting me to come and share this fantastic event. We've got a really good session ahead. Everyone can hear me, so that's great. I've been burnt before on that, so I'm glad everyone can hear. So sorry, I should say that my name is James Malcolmson. I'm a cardiac physiologist from Barts Heart Centre, and I'm in the later stages of a NIHR funded clinical doctoral research fellowship. So I'm a cardiac physiologist by trade with a special interest in research. And we've already got a really good session for you this afternoon. This webinar is entitled The Essential Toolkit for the Modern Cardiac Scientist. And I hope that's what you're expecting. If not, stick around, because I think it should be very, very interesting with some informative talks, some great talks, and some thought-provoking discussion at the end. So some brief housekeeping. Feel free to put questions in the chat, keep muted, etc. But for questions in the chat, the way we're going to do it is we're going to have the talks with a 5-minute break halfway through between session 1 and session 2. Some further talks, and then there'll be the opportunities for us to pull all those questions together as a panel at the end, and hopefully have, like I say, a really good informative discussion. So let's move on to the elusive toolkit. That's the reason why we're here. And I'm not talking about that box under your stairs with, unbeknownst amounts of unused IKEA furniture fittings in. I'm talking about something that we use every day, knowingly and unknowingly in our working week, which contains elements of undoubtedly leadership. So there may be periods in your week where you need to take up a leadership role in whatever form that may be. It may be that you're teaching in your role as a cardiac physiologist, cardiac scientist, be that with students, undergraduates and above, colleagues who are more junior or learning a new technique, and the wider multidisciplinary team. There'll be elements of the week, even if you're not officially say in inverted commas, a manager, there will be elements of your week that involve managing staff, people, students, etc., managing lists, for example. So there will undoubtedly be elements of management within your working week, even if you're not officially a manager, as I say. Some of you will be directly involved in academia and research, and this is a continuum where that involvement and engagement could be something as simple as helping out with a quality improvement project within your department, right through to leading randomized controlled trials as the primary author. Your clinical expertise is something that this is obviously a key element of your toolkit as a clinical scientist. This is something that you use every day. You're trained to do. You're accredited. You may be even dual accredited in multiple disciplines. But your clinical expertise is obviously one of the core pieces of that toolkit, and possibly the most drawn upon. And we'll hear today as well about some of the other areas, such as clinical assessment. So things such as taking a detailed and valid history from a patient prior to the test, or even listening to their chest, doing a clinical assessment as part of your daily practice, and even advanced practice in some cases. So this is the toolkit. This is what I mean when I say the essential toolkit, and this is what we're going to have some fantastic talks on today. So without further ado, I will stop sharing my screen. I hope. Do excuse the road noise outside. They've just started drilling up the pavement with great timing. So I'll stop sharing and hand you over to Amy Dutton from Wythenshawe Hospital to talk about leadership and cardiac physiology. Amy, if you can hear me, do crack on. I think you maybe still be on mute, Amy.
Classic. After 2 years, you think I'd have learned by now, wouldn't you? Sorry, this afternoon, I've been tasked with talking to you about leadership education for healthcare scientists. My name is Amy Dutton. I'm an expert lead cardiac scientist at Wythenshawe Hospital, which is part of Manchester University Foundation Trust. So what is leadership and why is it important to us? Well, my sort of favourite definition of leadership is that it's the art of motivating a group of people to act towards achieving a common goal. So leadership captures the essentials of being able to inspire others while simultaneously directing the way that they act. You've got to be personable as a leader. You've got to be personal enough for other people to follow your instructions. And leaders must have critical thinking skills so that they can know the best way to use resources within their organisation. So I qualified as a cardiac physiologist in 2007, and clinical leadership really didn't come into my consciousness until about 2010 with the release of the Francis report. That was looking into the failings of the Mid-Staffs NHS Trust. And of the 290 recommendations that were given, the most significant section of that was devoted to improving leadership within that trust and the wider NHS off the basis of the report's findings. It talked about promoted shared training and shared code of ethics on a leadership framework so that they could enforce standards of accountability, and also placed emphasis on the requirement of leadership at all levels of the NHS. More recently and up to date in 2019, it was part of the NHS long-term plan that to deliver great quality care within the NHS, we're going to need great leaders at all levels. They evidenced that quality care and organisational performance directly affected the quality of leadership and improvement cultures within NHS trusts. It was backed up in healthcare science primarily in March 2020 when we delivered the NHS long-term plan Science in Healthcare report that was delivered by the Chief Scientific Officer, Professor Dame Sue Hill, and that made as a priority leadership for transformational change within NHS organisations. And then we've had more sort of drill down in cardiology. We've had the Sir Mike Richards report, which has looked at diagnostics, recovery and renewal, and there was a specific recommendation within that report that placed clinical leadership at the heart of diagnostic disciplines at a national, regional and local level so that we could drive a change programme in the COVID recovery and the uptake of diagnostic services after COVID-19. And for all of those things to be put into place, we were going to need leadership. And then we had the GIRF report that came through in February 2021 for cardiology, and that is looking at enhancing patient care pathways, digital transformation and improving procurement within cardiology. And that's going to need leadership at every level to design and deliver cardiology services for this post-COVID world. So leadership isn't just about what role you're in. It isn't which point of your career you're in. It's not defined by a hierarchical status. Anybody can step up and lead. And as healthcare scientists, we contribute 80% of the clinical decisions made within the NHS. We represent a massive untapped resource of leadership. It's important to have inclusive leadership where staff feel confident in expressing their true selves, raising concerns, admitting mistakes, where they don't feel they're going to be unfairly judged. And that correlates with improved sense of patient satisfaction, lower rates of infection, lower mortality rates, better CQC ratings, better financial performance, as well as lower turnover and absenteeism. The National School of Healthcare Science has a new STP curriculum that is coming out this year, for the new cohort. That firmly places leadership at the heart of it by having learning outcome 10 in the professional foundations, healthcare and clinical science module. And that's going to require trainees to develop and demonstrate leadership appropriate to their role and practice, and adapting the appropriate leadership style for what they're undertaking. For anyone undertaking equivalence, domain 5 is a massive domain of evidence that you're going to need to submit for equivalence, which is all about clinical leadership, and some of the courses that I'll talk about in a second will help you evidence that. And the HCPC have also launched a review into where they place leadership within their standards and sort of bumped it up from just being a knowledge criteria to an actual demonstrable skill set when dealing with other people and working alongside other people, and how you interact appropriately with your colleagues, your peers and people that you influence. So my leadership journey then started in 2014. Prior to that, I'd had no formal leadership education. I was already a band 7 in a major tertiary cardiology centre, and my line manager suggested an opportunity to apply for undertaking a leading transformational culture change programme. It was at the time being run on behalf of Health Education Northwest and the Northwest Healthcare Science Network, which don't really exist today in that form. But it was 5 modules of 2-day residential courses with a final presentation, a final poster, and the opportunity to do 2 extra reflective written assignments for an Institute of Leadership and Management certificate. The attendees on that course were all senior healthcare scientists and science roles. So you have biomedical scientists, medical physicists, people like that. And I undertook a quality improvement project as part of that course to develop a transient loss of consciousness clinic. That involved an audit of A&E syncopal episodes, and it was out of that project that I was able to go on and develop the Physiology healthcare scientist loop implant service that we currently have at Wythenshawe, and that's evolved ever since, really. In 2017, I went on to undertake a more national recognised leadership programme, which was the Mary Seacole programme. There is a raft of NHS Leadership Academy programmes at every level, but this one required me to do 100 hours of online study. There's interactive content on there, there's discussion threads on there, so you're constantly getting feedback from your peers. There were 3 face-to-face workshops with an expert facilitator, and it looked at things like the fundamentals of appraisals, annual reviews, negotiating NHS finance, things that will help you in service improvement projects. And at the end of that, I had to write a written assignment looking and reflecting at my leadership impact whilst I was on that course. In terms of career development, at that time in March 2017, I'd just taken the expert lead role for Cath Lab and EP here at Wythenshawe. So the leadership training that I'd done prior to this and the part of the Mary Seacole gave me evidence of leadership skills and gave me a proven track record of service development that allowed me to answer some of the interview questions that came up at that interview. So that was really helpful. As of 2021, I'm currently on the British Cardiovascular Society Emerging Leaders Programme, which is ongoing. And as part of that, I am developing a service development project to take our existing healthcare science assistant practitioner workforce and to enable them to become multi-skilled in cardiology and respiratory diagnostics, venipuncture to provide services in our cardiac diagnostic hub. That's going to be presented as a poster at completion of that course in June at the British Cardiovascular Society conference. So the NHS Leadership Academy have a range of courses. The Edward Jenner course is really useful. That's free, it's online, anyone can start that as of today. It's for your first initial introduction into leadership. Mary Seacole requires departmental support. It also requires departmental funding, and that's sort of the entry level sort of early career leadership course that you might want to undertake. They then go up in progressive sort of intensity and duration right up to Elizabeth Garrett Anderson, which is 24 months and leads to a master's in healthcare leadership. You will need the support of your department for funding and for service improvement and quality projects. You will need your backing of your department to undertake these. What's also really important in terms of inclusive leadership are the Stepping Up and the Ready Now programme, which encourages Black, Asian and ethnic minority candidates to go and take leadership courses so that we can get fully inclusive and diverse leadership right up to board level in the NHS. There's also the NHS Leadership 360 appraisal tool, which is if you take something like the Mary Seacole or the Emerging Leaders programme, you will be given the opportunity to do this as part of that programme. This involves undertaking a 360 appraisal where you get feedback from your peers, from your line manager, from people that directly report to you. And you undergo looking through the report with a facilitator that you select from a broad range of facilitators nationwide. That might be virtual or face-to-face, depending on the circumstances. And it looks at all of the different things, the different areas of leadership that you might want to improve on, looks at your strengths and weaknesses. There's also the option, if you're doing equivalence and you want to evidence that you thought about leadership, you might be able to do that outside of one of the programs. You can just apply to do one of these appraisals off your own sort of back, but it will require a small fee. However, I would strongly recommend that you have some formal leadership training in place as well, just to work on the weaknesses that might be found from the appraisal that you undertake. The facilitation aspect is really important because you're getting anonymous constructive feedback, which on the first read through can be a little bit eviscerating. So you will want to go through it with your facilitator just to make the best of that information. And then there's the British Cardiovascular Society Emerging Leaders Programme, which is the current programme that I'm on. It's now in its 3rd cohort. It was traditionally geared towards late-stage cardiology trainees and new consultants. It's the first year it's been opened up to healthcare scientists, cardiac radiographers and arrhythmia nurses, so allied healthcare professionals. So it's a great opportunity for us. High calibre faculty run in association with the American College of Cardiology and the King's Fund and other high-level speakers from around the NHS. It requires you to put in an expression of interest statement, a CV and a supporting letter from your department. Again, you need strong departmental support. It's been run virtually over COVID, but I think that will go back to face-to-face in good time. It looks at NHS infrastructure, cultures, behaviours, looks at how you map out your leadership journey over the course of your career. And then finally, there's the King's Fund. They're an independent charitable organisation to improve health and social care in England. And in 2011, they wanted to shift the NHS away from this sort of heroic leader at the top model to a more inclusive form of leadership at every level that's compassionate and inclusive. They've got a range of leadership programmes. However, I would sort of caveat that with saying some of them are a little bit expensive. But it's whether you can access that funding through your department. That would be fantastic to get on one of those. But an early win is to go and look at Future Learn and the King's Fund collaboration. They've put together an introduction to leading with kindness and compassion in health and social care, which you can access very easily and do in your own time, or, you know, sort of alongside your clinical role, and there's no fee for that. So in summary, I feel like that's been a very whistle-stop tour of some of the things that have been available to you. But your leadership journey can start alongside your initial clinical training, and anyone can start developing a leader anytime, irrespective of role, band or clinical experience. There are lots of easy wins out there in terms of the free learning opportunities. And I neglected to say there are bite-sized learning packages as well on the NHS Leadership Academy, which are free and online that you can do. You can then go on and apply for high-level leadership courses if you can secure the funding and support from your department. Also look out for things in-house in your own trusts. Several trusts offer local leadership development courses, and you can also improve your leadership skills every day in your role by taking on new things like leading meetings, audits for service improvement, undertaking appraisals. They're all great things for developing and evidencing your leadership skills, evidencing for equivalence, or just generally enhancing your CV. Thank you for listening to me this afternoon, and I'll be happy to take questions in the panel discussion. Thank you.
Thank you, Amy. That was a fantastic précis of leadership in cardiac physiology, and you've reminded me two really important points, which is one, that, you know, people are often thrust into leadership positions or find themselves there without any real training on how to lead teams or people or groups. And the other is that there's much that can be done, both free, paid for, and others, courses that can be provided and undertaken that can really help anyone develop their leadership skills across any, you know, in any position at any level. So I think that's something to, you know, these are the things that managers should be aware of, to discuss with colleagues during appraisals or one-to-ones, etc. And the other very brief thing I want to say is that the assistant practitioner program sounds absolutely fantastic, and you've brought up a clear link between service development, clinical expertise at a particular level. You're going to write that up as research. You're going to present that as a quality improvement project or otherwise at a conference, and you'll have to develop your leadership skills and in order to do so, to run that program. So these are not siloed skills or points of the toolkit. There's a lot of overlap between. Is that fair?
Yeah, absolutely. It's definitely driven by going into some of these formal leadership programs. It's driven how I've looked at service development, improving the services that we deliver for our patients within our centre. So it's not just about going on it and developing yourself in a silo. It's about taking everyone with you and taking your service with you, and you can kind of build on that. And it's not just doing one as a one-off. You can see I've done, you know, I'm on my third leadership course now, and I'm learning different aspects and different things all the time from them. So it's a lifelong journey, really.
Long way to do. Thank you very much.
Thank you.
Good. So without further ado, we'll move on to Anna Domingos, who's also from Manchester. I believe it's the Royal Infirmary, but I'll allow her to introduce herself properly. She's going to talk to us about the clinical examination and history taking.
Thank you, James. I'm just going to share my screen first. First of all, I wanted to thank you to BHRS, Stuart and Larry specifically for the invite to share my experience on clinical examination skills and the patient history taking. I am a highly specialized cardiac physiologist at the MRI, which belongs to Manchester University NHS Foundation Trust as well. So on my journey of clinical examination and patient history taking, I actually did this course back in 2017 when I was a cardiac physiologist in Cambridge, in Addenbrooke's Hospital. So my manager at the time motivated me to actually go and enroll on this course to have a more extensive understanding of how to assess a patient and how to take a history properly. So that was very interesting, and definitely I'm very grateful for that experience. So going forward, I just wanted to show a bit of what courses we have at the moment and what other colleagues have done so far. So apologies for showing just a bit of what we have in the north area. I'm sure there are much more courses around the country, but I'm just going to share what I know, what my colleagues have done, and myself. So starting with a very close university, so Manchester Metropolitan University in Manchester. They have also this kind of physical examination skills course. The duration of the course is 11 weeks. So this is directed to a wide range of healthcare professionals. So it's not just for cardiac physiologists. So you can find nurses, you can find other healthcare professionals that actually want to get this kind of set of skills. In terms of credits, if you do this course, you will get 20 credits at level 7. And the assessment itself, it involves 3 parts. So you have a practical examination, which is basically an OSCE. You have also a clinical assessment tool, and you also have a part of written assignment as well. So this is what they have at the MMU at the moment. I have several colleagues that already did this course, and they were actually quite pleased with it. Another university nearby that runs this kind of clinical examination skills course is the University of Bolton. The duration of this course is a bit more extended, so it's up to 1 year. But it's based on the same levels, on the same ground. So they combined basically a range of skills that people will be able to get by the end of the course, which will be auscultation, general clinical examination, and also patient taking history. So this course also, you can obtain 20 credits also at level 7, so masters. The assessment itself is 50-50, so you have the coursework, which will be written assignments, but also a practical exam, which will be an OSCE as well by the end of the course. The third and final course that I'm going to talk about is the one that myself I did, and some other colleagues as well. So I can talk a bit more about my experience on this one. It was at Swansea University. So this course is specifically designed for healthcare scientists. The places are quite limited. So usually they have 8 places per year. So it's quite limited per year, but it facilitates a bit more of focus, and I think we can have a more face-to-face approach with our mentors there as well. So in one hand, I know it's difficult because it's just a limited amount of spaces, but I think it's also good in that perspective. So they actually designed this module to be on the same basis of the STP equivalence. So they had that in mind, so we could actually use this kind of course to then work towards an equivalence, which I'm actually doing at the moment. It is a 30 credit module, so not 20 like the other ones before, but a 30 credit module. And it's actually based in face-to-face appointments over there at Swansea University, but majority of the work is done in your hospital. So usually you should have a mentor that is assigned to you, that should be a cardiologist, a consultant, that will review your practical work in hospital, all your assessments, all your face-to-face with your patients. And then you have 4 modules at university, which include general patient history taking, general examination, and then they focus a bit more on respiratory examination and cardiovascular examination. So those are the main focus on this course. In terms of written assignments, it's quite an extensive work, but I do find that it was really, really helpful, especially now working towards an equivalence. It really helped me to work on a master's level, basically. So this kind of clinical portfolio that's actually 75% of the assessment, it includes a scope of practice of a clinic that you would want to do in the future. So when I say clinic, it's a physiologist-led clinic. So you need to write a scope of practice of this clinic that you would like to do in the future. It involves as well, it includes a case study where you need to explain all the pathophysiology behind. So actually it helped me to study and review a bit more on this. So I think it's very helpful as well. It includes critical reflections and the final assessment, which is at the hospital with your mentor. It's an OSCE. So basically you will have a patient that your consultant will pick. You don't know anything about, so you have to do a full patient history, do a full examination, and then you will have to provide a final diagnosis considering the patient that you took the history and the clinical examination. So I found this course was actually quite helpful. And after I did this course, I actually realized how important it was to know how to approach our patients in a daily basis, and actually motivated me a bit more to direct my career in a specific pathway. So I was actually more interested in working with patients that are diagnosed with heart failure. So I will explain a bit more further where we got to now in Manchester with our clinics, but this is how this course has actually motivated me to work a bit more towards this kind of specialization. So why is it important to have this kind of set of skills when we deal with our patients? I mean, I think we can use this set of skills on our daily practice every day. When we come across a patient that is complaining of a new onset of symptoms, we shouldn't disregard, of course, and I'm not saying that we do, but if we do have some kind of training on how to approach the patient methodically, we won't miss anything. So definitely on our daily practice, in each environment, it could be either a cath lab environment, it could be a clinic environment, it is of extreme importance to know how to approach these patients step by step. Also, we don't have a consultant around all the time. So if we do have a skill of clinical examination and we can listen to a patient's chest whilst we're doing the clinic, we can understand if the patient, for example, heart failure is deteriorating or not. So, and we can take some action on it. So I find extremely important to have this kind of skills. Also, unfortunately, appointments with our consultants could take longer, and in the meantime, the patient could deteriorate. So if we can provide that in the same clinic, in the same appointment where we are, for example, doing a device check, that is the best care that we can provide to our patients. So why not? Last but not least, of course, having this kind of set skills allow us to have more independence as physiologists. So we don't need to get one of our consultants to come around and do this. So we can do it ourselves. So of course, it will give us even more independence as cardiac physiologists in our daily job. And more important, we can streamline our patient care. I think this is the major goal in having this kind of set of skills. Like I said before, we can apply this in many occasions in our everyday when we come across our patients. But I would like also to mention how important this could be in our future career, how we can use this clinical examination skills to create our physiologist-led clinics. So I'm just giving here a brief example of some clinics that we could create on the basis of these skills, but I'm sure there are much more that can be created upon this kind of skill. So you have valve clinics being done by physiologists, so completely physiologist-led clinics. You have heart failure clinics as well. Myself and some other colleagues are doing that. We could have syncope clinics. And for example, for a syncope clinic, I think it would be extremely important when you are implanting, for example, ILRs, to follow up your patient from the moment of diagnosis to actually implant your ILR. So your patient will just have to know one person from the beginning until the end of the treatment. So I think in terms of patient reassurance, that is also quite good in this kind of syncope clinics, for example, instead of going in several circuits with the consultant and with the physiologist. So I think this would be a good idea as well. You also have palpitations clinic being run by physiologists, and also some VT clinics that you could create based upon this kind of clinical examination skills. So this is just a brief idea, but there is an endless horizon of clinics that could be created. So, of course, physiologist-led clinics are a big motivation, so we can gain more independence, but they're also a big responsibility. So it's quite scary to actually start this and not having a consultant around. So I'm just going to give here some suggestions that I think from the course when I did, they also advised, and I think it is important. So when you create this kind of clinics, it is of course important in the very beginning that you can have a close contact with the consultant. So I would advise possibly if you could have a review weekly of the patients that you see in your physiologist-led clinic, just to make sure that you are taking the right decisions and you don't feel alone, of course, in taking those decisions. So I think it is very important to do that in the very beginning as well. Also important, as you know, in our daily practice, but even more with the physiologist clinic that you are running, regular audits on the very first year and consecutively would be very important, so you can understand what are the pros and cons and limitations of your clinic, and also what you could learn from and what other directions you could take from it. So audits definitely are very important if you are creating a new service as well. And also it is important to understand that these kind of skills shouldn't be used on your own. So yes, you can have a physiologist-led clinic, but you can work alongside with other professionals. So there are also combined clinics, for example, physiologist nurse-led clinics that you could create as well, because unfortunately at the moment we are not able to prescribe medication. So if you have a patient that you need to titrate medications and review, if you can have someone on your side that you can work on the same clinic, you can treat the patient in one go, if that makes sense. So combining these kind of skills alongside with other professionals, that would be also a very good idea, if possible. So I just want to give an example of our experience at the MRI CRM team. We currently have 7 physiologists that have done this clinical examination course training. The skills that we have from these courses are actually applied in a variety of clinics. So we have comprehensive CRT clinics that are also supported by our cardiologist, a heart failure consultant, but we apply those skills there as well in those patients, pacing clinics. And also we have we piloted a physiologist-led heart failure clinic for 2 years. So we have been applying our skills in that clinic, and the outcomes have actually shown an impact of streamlining the patient care before they actually decompensate in symptoms. And the aim is definitely to reduce the number of hospitalizations. There are more clinics, of course, that are in the scope of other physiologists to be created. So I'm looking forward to see many more clinics coming like this in our center, of course. And it is also very rewarding, to be honest, that other specialties recognize this set of skills of extreme importance. So I think we are very well supported. Our leadership is also very good in motivating us to do this. So I think in our center, we are actually very motivated to continue this kind of physiologist-led clinics. Just about to finish, James, just showing what we do in this physiologist-led heart failure clinic. So we do a telephone triage where we assess the patient, and resulting on these questions, we usually send the patient to our clinic, and then we assess the patient clinically. After that, we either refer the patient for an MDT if they need meds review or anything else done, or if we have a consultant around, we can always ask for advice. But yeah, if something falls outside our scope of practice, we refer to the specialty that needs. So just wanted to say that there are several universities at the moment that provide this type of course in a regular basis. This is definitely a step forward in our career as a healthcare scientist. So this is very important if you also want to work towards an STP equivalence. And last but not least, the aim is to provide and streamline our patient care in the best possible way. Thank you very much.
Thanks so much, Anna. That was a lot to fit in. I appreciate we squeezed you into 10 minutes or there or thereabouts. So it was a lot of information to get in. And thank you very much for giving us an overview of those, formal courses available, and also underlining the fact that it's such an important skill set to have. No matter what area you're working in, you could be, doing ECGs in clinic and be met with a patient who doesn't, seem quite right or doesn't seem quite well. So those skills could be put to fantastic use at any level, any scenario you can think of. So thank you for the tips for successful application of those skills in an advanced role. And I'm sure we'll talk about that a lot more in the discussion. And you also mentioned the importance of audit and an evaluation of these services as they're set up. And again, that links, in the interest of time, we'll move on to the next talk, but that links very nicely with our next talk. So thank you, Anna.
Thank you, James.
And the service evaluation, audit, and continued evaluation of these services links nicely with research, which is where our next speaker, Leeann Marshall, from Coventry, will be talking. So Leeann's going to talk to us about research options in cardiac physiology.
Okay, I'm just going to share my screen. Lovely. Yeah, hopefully you can all see that okay.
Yeah.
Lovely. So my name is Leeann, and I'm the Joint Head of Cardiac Investigations for University Hospital Coventry in Warwickshire, and I'm also a PhD student at Coventry University. So I wanted to give you a little overview about me and kind of how I got into research, and maybe bust a little myth along the way. So I graduated from Leeds University 2012 and carried on and started work at the QE in Birmingham for 4 years, did my BHRS qualification, and then eventually moved to University Hospital in Coventry, where I'm now Joint Head of Devices, and I've also done my STP equivalence. And one of the things I think confused me when I started looking into research was, oh, I couldn't possibly do this. This is nothing, it's not in my remit. I'm a physiologist, I can't do research, which is completely wrong. And one of the things I found very surprising was I don't have a master's qualification, and you don't have to go on to do PhDs. And you'll find a lot with clinical PhDs, it's not a requirement. The minimum requirement I found for my university was a 2:1 bachelor's, and it did surprise me. And I didn't fully believe it until I was completely enrolled at Coventry University. And just to kind of prove it there, I don't have a master's at all. So how did I end up doing a PhD? I kind of fell into it, and it was a lot about observation and conversations with my consultant. And I actually went up to him and said, this is interesting. It was actually an observation that he'd made. I find this interesting. This is something we can do with this. And within a couple of months, he'd come back and offered me some funding. It's a little atypical, certainly. It's not the normal pathway, but it's been quite fun for me. To give you an idea of my basic week, I'm actually 50% clinical, 50% research. And what's wonderful is it keeps my clinical skills up. And my PhD is informed and works alongside my clinical. And it's all about my ICD patients, their journey, their well-being, which means I can keep going on what I'm doing. There's no takeaway. The department is still getting me there to work. I'm just adding more to the department by doing all this research. And it's helping me as well, and I'm progressing further because of this. And actually coming back to what Anna's talking about, is I've gone on and doing my clinical assessment stuff at the moment at Swansea University. So I'm upskilling in that way. And I'll be going on to create Physiologist-led VT clinic as part of my research. So all of this research really pushes you and the department forward. So it's a fantastic opportunity. So kind of how can you get involved in research? And it's along the same lines as how I got there. It's observation and conversations. You guys are in clinics all the time. You're seeing these patients regularly. You're seeing what's going on, and you might notice a correlation. Well, this cohort of patients, every time they come through, this happens. So have a look into it. There's always clinical audits and improvement projects going on within your department. Speak to people and get involved. You get to know whether it's something you're actually interested in. Research isn't for everybody. I enjoy it. I really enjoy it. But you need to know that that is something you would like to do. Talk to the consultants. If they're anything like my lot, they are full of ideas. And more often than not, they don't have the time to go on and make these projects happen. So they'd be more than happy to pass something on to you. Trust me, the amount that I've been given is insane. And in the same way, talk to the registrars. And this is how I got my first taste of research, was doing a project with one of my registrars. And I sat and went through a spreadsheet of 512 patients. And the output we got was fantastic. And I'm still shocked by the results we got. And it was really, really interesting. Get involved in writing up papers. A number of my colleagues have done this, and they've got involved with abstracts. Writing method sections. You don't have to write the whole paper. You can write it with somebody and just get that taste of that clinical writing, that academic writing. And getting involved with poster presentations, getting yourself to conferences, getting yourself out there and reading. Read papers, read things that are out there, get an idea of what you're writing. Obviously, I am doing a PhD, and I'm probably kind of going to stay more on that PhD side, but there is the options to do a Masters of Research as well. If you don't want to go jump straight in and the doctoral level, you can go and do a Masters. So there are kind of 3 routes in, and then I'm really going to talk about 2 of those. There's the doctoral college, big book thesis, which is what I'm doing. And for me, that's 3 years full time, and it's produce a thesis at the end of that, it's 80 to 100,000 words, which is slightly terrifying. And there's also the absolutely fantastic HSST, which we have access to. And obviously my colleague is going to talk about that a bit later on. But that is an incredible opportunity for us to go on and do these higher level degrees. You just don't get this opportunity anymore. It's a fantastic opportunity, honestly. The third one is a PhD by publication. It's not a traditional route. It's essentially you enroll at university and you produce several publications over a period of time to gain that PhD status. So where do you start? I mean, I've told you that the way mine started, I was just literally talking to one of my consultants, and it's snowballed from there. So do you have an idea for a project? As I've already said, have you noticed a pattern in your clinic that you'd like to investigate? Do you have a burning question you'd like to answer? what about a new intervention or process that you can evaluate? So part of my thesis is evaluating a new physiologist-led clinic. So this is all something that can be part of your research degree. You will need a supervisor, clinical or academic, or both. In my case, I have a clinical mentor, Professor D'Angel, and 2 academic supervisors, one under psychology and one under sports and life science. But you need that help. You can't do research on your own. You have to have somebody with PhD to supervise you. There's also university adverts. And again, this is something I wasn't completely aware of. On what fact, I didn't know we could apply for them. But there are always adverts out there from different universities offering these PhD places that are usually fully funded with a stipend, and you can just apply for them. One of the PhD students we have currently, the role originally went out via advert at Coventry University, but the offer was turned down, and it's now come internal to one of our members of staff, which is absolutely fantastic. Funding is the bugbear. Unfortunately, everything you do in academia requires funding, and that is not always straightforward. It's a lot of paperwork, but it is there, and it's worth it in the long run. Obviously, you can apply to the British Heart Foundation. The National Institute for Health Research do a lot of fellowships, doctoral, pre-doctoral fellowships, and you can apply to those specific times of the year. The doctoral fellowship is now twice a year. But don't forget about industry. Industry are fantastic, and they will throw money at you if you ask them to be honest. So part of my PhD is actually Abbott funded. Obviously other companies are available. Also the universities and the hospital you work at. So my chief medical officer happens to be a cardiologist, slightly lucky, but we did manage to get funding through hospital, through our R&D, and that was matched by Coventry University for me. And obviously the other option is you can self-fund. I've known of people that have self-funded their own research, their own doctoral degrees. And so that is always a possibility if you have the funds to do that. So the HSST, I'm only going to go over briefly because I know Lucy's going to be talking about it a bit later. But obviously this is a 5-year taught doctorate provided by the National School of Healthcare Science. And applicants typically require the STP, MSc or equivalence to be able to register. And the posts are commissioned via Health Education England, with the department getting 13,000 a year funding back, which can be used to backfill, but they do like you to use it as part of the training. And the department must be accredited, which you can talk to Health Education England, talk to the National School of Healthcare Science about how to become accredited as a department. And as part of that, you can qualify with a Doctor of Clinical Science. So one of the things I want to kind of make sure you're aware of is research is all around us. It's in everything we do. And as physiologists, we are fantastic. We are highly skilled, highly motivated, and we really are an untapped resource. When it comes to research, the first things the doctors think about is, let's get the registrars doing this, let's get them doing that. They don't always think about us, and we are in such a unique position where we see all these patients coming through to clinic that the doctors don't see. We can see things they don't. So I think it is really important to try and get more of us involved. And that it's there, it's within our reach, and I want everyone to reach for it if they can, if you're interested. Obviously, it's not everyone's cup of tea, unfortunately, but anything we do within research will inform our own clinical practice. As I've said with my projects, it's changing the way we are doing things within our department, and it's creating a better streamlined workflow for my patients, and hopefully that will provide a better clinical outcome in the long run. So it's all beneficial for you, for the patients, and for your department. So please, please, please consider going into some form of research, even if you're just doing audits within the department. They're so important. And just thank you for listening. And obviously my contact information is there, and I'm happy to take questions at the end for the panel.
Wonderful, thank you, Leeann. That was really, really informative. And there's a couple of points just very briefly before we wrap up the first session. Yeah, you you underline the fact that it really is all around us, and in everything, you know, we can come across some form of engagement with research in every aspect of our work. It might be that you're collecting some data. You might not even know you're doing it. You might be collecting data for a sort of industry-led study in the lab or something like that, or you might be actually doing like you said, collaborating on the writing of a section of a paper or a protocol or something like that. It's a continuum, isn't it? There's many things along that continuum that we can do without too much diversion or extra effort from our working week, and that can really enrich our that area of our toolkit and give us the experience that in that area.
Certainly, yeah.
Hello, welcome back. We're going to crack on with part 2 of the webinar now, if that's okay. So I'm going to give a very, very brief overview, an introduction to the National School of Healthcare Science and their education pathways before handing over to my esteemed colleagues who are going to talk at the various levels of training and development and progression within their careers, right through from the undergraduate program through to the higher specialist scientist training, or HSST, which is the route to consultant clinical scientist. So let me just share my screen briefly and take us to, here we are, let's go. So yes, I should have expanded this acronym, apologies. It's Introduction to Progression in the Eye of the National School of Healthcare Science. So the National School of Healthcare Science are part of Health Education England, and they're responsible for the education, training and development of all healthcare scientists within the NHS. And that's a big group. There's 4, I think I alluded to earlier, four disciplines with many careers within. 50, I think it's around 54 different careers contained within those. So we are one of those themes in physiological sciences, and only one small cardiac science is only one small area of the physiological sciences. So this you may or may not be familiar with. This is the sort of routes for progression. It's a busy slide, apologies, but it is their sort of standard schematic of the different routes into and through healthcare science careers. So I want to bring your attention with a nice red circle to the PTP, or the Practitioner Training Program, which is the undergraduate entry-level Bachelors of Science degree. Once you've done that, you could then undertake go through to take on an equivalence route or a progression route from the PTP through to what we call STP, which is the Scientist Training Program. And the equivalence, you could, if you're already a qualified member of staff, like I said, you could undertake the equivalence process, which we're going to talk about today, in order to give you equivalence at scientist level. Once you've undertaken either been through the Scientist Training Program, the formal 3-year program, or the equivalence process at that level, you can then register with the Health and Care Professions Council as a clinical scientist. And you'd need that registration if you wanted to enter onto the higher specialist scientist training, which really is obviously very few people go on to do this, but this is, like I alluded to, the route towards consultant clinical scientists. And we've got some fantastic speakers now, I hope, who are going to jump in and describe those areas in a little bit more detail. So I will stop sharing my screen. There we go. And I'm hoping that I can hand over to Sam and Paula from St George's University to share their presentation on experiences of their undergraduate program that they're doing in London hospitals. So Sam and Paula, are you able to? Fantastic, you're here, well done.
Hello, hi. Hello everyone. It's such an amazing turnout, and what a lovely opportunity to hear everyone's different presentations. I am a student at St George's University. I am currently doing the BSc Healthcare Science programme, and I'm actually placed at King's College Hospital. And I'll just hand over to Paula to introduce herself.
Hi guys, so just like Sam, I'm undertaking the same undergraduate program as St. George's, and I'm currently in placement at Kingston Hospital.
Lovely, I'll just start sharing my screen now. There we go, and let's just see to get the slideshow up. There we go. Okay, so I'm just going to start off by briefly discussing the skills that Paula and I and our peers are kind of developing to be a healthcare scientist. So like some of our colleagues have mentioned, we are the backbone of diagnostic testing within hospitals, and for that we have to develop very specialist scientific skills that we kind of learn about theoretically in our first and second years, and then we get specialist kind of teaching in our third year, and we bolster all of that teaching with the clinical placements that we are currently doing 30 weeks of in our final year. So it's very clinical, clinic kind of heavy, but you know, it's great because we get that direct patient contact from quite early on. A major aspect of the role that we take on and that we learn during the undergraduate degree is that we are contributing to a multidisciplinary team. So we need to be great at communication and work in the best interests of our patient. And, you know, contributing to these teams can be quite daunting, but as everyone said that previously, we are definitely an untapped resource, and I think it's really great that, you know, our career paths are kind of developing so much, and it looks like there's an amazing future ahead of me and Paula as well, so it's very exciting. So I'll just hand over to Paula, who's going to talk a bit more about course structure.
Okay, so I just wanted to give everybody just kind of a brief overview of what our course looks like and what we've been doing for the last 3 years. So the healthcare science program is taught for a 3-year period, and during that 3-year period, we have within the first and second year, we have certain modules which are shared between our different specialties, between the medicine, biomed, stuff like that, which gives us sort of a broad foundation of knowledge about different body systems and diseases that affects it. Also, just to point out that St. George's is the only university based on a hospital. We study in a clinical setting and we adopt a very patient-centered approach from the outset. And once we're put into these clinical placement, it kind of just helps us sort of just build our confidence a little bit better and helps us be better competent in our skills. So as Sam previously said, our clinical placement is, we undertake 50 weeks of clinical placement within our 3 years. It's split between 9 weeks in the first year, 12 weeks in the second, and 25 in the third, which unfortunately has been changed for us because of COVID, and now we have to complete an additional 5 weeks on top of having to do our dissertation and all other 5 other modules we have to do at the same time, which is a little bit tasking.
So considerations for prospective students. This is a degree that requires clinical placement settings. So we get direct patient contact, and that starts in the first year, which is great for us. It's very exciting to be kind of put into those situations. At George's, we do cardiac and respiratory placements in our first year to get a bit of an idea about what we're more suited to. Paula and I both chose to do cardiac physiology routes, but my flatmate actually does respiratory and she's really enjoying that too. But it's nice to kind of have exposure to both and choose. Like I've said before, we kind of we start by observing routine and highly complex procedures, and we have to create kind of a portfolio and have competency signed off throughout first, second and third year to create kind of a portfolio that we submit at the end of our final year. the environment that we're in and the practices that we deliver requires teamwork. So if you are considering a career in cardiac, in healthcare science, getting kind of experience in teamwork is going to really help you with the kind of application for that. You're working with patients of all ages. I've mentioned my flatmate before. She's actually at Gosh, working with children with congenital kind of respiratory conditions and heart conditions, which is great for her. I definitely say that on my placement, every single day is different. You can't really plan ahead, but that's what makes it so exciting. In terms of further study, I'm not really sure what your plan is, Paula, but I have applied for the STP programme. And I'm really, really hoping that that's going to go well, because it's such a great opportunity. And then the HSST beyond that is obviously very far ahead in the future, but definitely worth thinking about. And like everyone else in the talk has kind of focused on, the scope for progression in this particular career is so broad, and there's great opportunities for publication of your research and things. So we're definitely getting there with all of that. So that's where we're hoping to head as well. And I think we'll just leave you with this image that I found online the other day. And as me and Paula are kind of baby physiologists, I think this is a really helpful picture to kind of look at, that everything is achieved in those small steps. So yes, thank you for listening, and thank you to BHRS for giving us this opportunity to talk. And James, thank you very much.
Thank you very much, both. Thank you for firstly for coming and joining today at relatively short notice. And I think you put together a really good talk in it with a quick turnaround, and for giving us a nice overview of the undergraduate programme. I know you guys are both at George's. There are universities up and down the country that run this course, and I know one of the things that they find is that it can be difficult to find centres to place their students at, because if you take 25 students on a course, excuse me, you need 25 plus hospitals to place them at, depending on how many you can place. So if there's people in the audience who are thinking about, haven't yet engaged with the undergraduate or PTP program, I think it's really important that we try and do the best we can to do so, and support these students who are obviously very capable, very driven, and are going to form the next step in our workforce. So do get in contact with centres that have established programs. The paperwork is not as scary as it might seem. They're covered under the Learning and Development Agreement with Health Education England. So yes, do take these students on, and thank you very much, guys. That's really, really great.
Thank you.
So in the interest of time, we'll move straight on. I'm sure there'll be questions about the undergraduate programme, but in the interest of time, we'll move straight on to our next speaker, who is, correct me if I'm wrong, Shahini Desai, who is going to talk to us about her experiences of being a sort of STP guinea pig, as it were.
Yeah, I can't share my screen at the minute whilst it's being shared elsewhere. So I will stop sharing your screen.
You're quite quiet, Shahini. I don't know if you can make yourself a little bit louder.
I'll just shout a bit louder. I can't share my screen until Sam's unshared hers, if she doesn't mind.
Well spotted. Sam, if you wouldn't mind.
Yeah, can you see and hear me okay now?
It looks good. You're a little bit louder as well, but do keep the volume up.
Okay, great. So for those that don't know me, my name is Shahini Desai, and I'm a senior cardiac physiologist at Barts. I'll be talking to you a little bit briefly today about the STP, as I have done this course and I've finished in 2020. So I'll talk a little bit about my experience, give you an overview, and give you some insight into the possible journey into the career. So what is the STP? The STP is a 3-year program, and it kind of combines work-based learning with university taught modules and assessments. So as opposed to the
Shahini, sorry, I can't. Sorry to interrupt. It's not gone into presentation mode for me anyway. It's still on the first screen.
I'll try again. Is that on?
Much better.
Okay. So to differ from the undergraduate course, STP students are based at an NHS trust for the majority of the time, and they're released for university a couple of weeks at a time, sometimes about a month or so, to undertake the academic portion of learning, and the rest of the time is spent hands-on doing placement practice of the clinical skills and academic skills they're learning. We spend time in a range of settings, and before you specialise in the last 2 years, you actually spend the first year rotating in different areas. So that includes cardiac science, so obviously cardiac science specialisms, respiratory and sleep science, vascular science, and you also spend a bit of time in clinical investigations. And I think the idea of that is just to give you a nice holistic approach to healthcare sciences. Everything ties in, and you get a bit of a wider exposure in that first year. In the second year, you then can go on to specialise further. Firstly, spending time in basic cardiac physiology, so that might be the catheter labs, getting involved in angiography and PCI procedures, and further on, even more than that, you can then specialise in echocardiography or cardiac rhythm management in the third year. So you get a little bit of exposure to both of those in the second year, see how you feel and how you get on, and then in the third year, you choose one route to kind of spend your time focusing. In terms of my experience, I've broken it up into the good for this slide. The first thing I think is really good about the course is the time spent on placement. Because you're here for the whole, for the majority of the time, you can really get stuck in. And I think with that, you integrate really well with your workplace. You're alongside your colleagues. Although you are a student and you're being supervised, you are there all of the time that you can really integrate in what they're doing, the training that's available to them, and get stuck in and observing as much as you possibly can. So I really like that. It was very hands-on in that way. And from early on, you are already practicing the skills that you're taught at university and putting them in a live setting with patients. I touched on this slightly, but the development opportunities, so that includes kind of training that's on site, also extracurricular training from companies that might come in, which is especially relevant to people pursuing the specialism of CRM, the project rhythm management. You're also entitled to kind of take on these opportunities, and I would highly, highly recommend that for students on the STP programme, because at that time you're kind of a sponge taking it all in. You get a study day a week. That might not seem like a lot for some students because there is an intense course, but it helps you to balance workload a little bit better if you maximise your study day. So that could be used to work on your dissertation, work on your university assignments. That might be case-based discussions or exam preparations. But that also can be used to work on the competencies required by the national school as part of the kind of portfolio side to the STP requirements. For me, it was very good because it was a route into the fields that I had already got a Bachelor of Science degree in biochemistry. So without having to go back to doing another undergraduate degree for another 3 years, I was able to kind of use this as a route in and earn a master's degree level degree at the same time, but kind of shift my focus from biochemistry to cardiac science. And the added bonus is that while you're an STP, you are getting paid a salary while you study. So that's always quite an attractive point of the STP for people. My experiences with challenges. So these are just some points to raise, that it's not all kind of plain sailing once you get onto the STP. Firstly, getting on can be quite challenging. It's very competitive. I'm not sure the numbers these days, but I know that it takes quite a process to get accepted in the first place, including applications, situational judgment tests and interviews. The benefit with the application process is that members of staff can enter either through their own service as an in-service application, or they can do a direct entry and apply to the kind of national scheme and look at at options up and down the country for where they would be based. It can be quite intense. There's a lot of content to cover in the curriculum, and it can seem very, very overwhelming, especially when you're spending targeted time at university for a number of weeks. Those weeks can become quite full on. There's a high amount of self-directed and self-motivated learning. So with it being a master's level degree, the onus is kind of on you as a student to take control of your education and make sure you're giving it the time it needs in certain areas and focusing where you need to focus. So that can be a big step up for students coming straight from the PTP, which is perhaps a little bit more supported from the university in terms of what needs doing. This when you're left on a little bit more of your own responsibility to tailor it where you want to go. Balancing the workload. So because you're spending so much time at placement and only those few weeks at a time at university, it can seem that you're far away and there's a lot on your plate in terms of assessments, essays and exams. But with that study day, it is manageable. You just got to be able to really focus your time and make the most of what you've got available. So if you can double up assessments and assignments, then that will help reduce your workload and manage it a little bit better. And finally, variation in submission, and exposure. It depends where you're based. So at Barts, we have a certain kind of patient population. Other hospitals will have different patient populations, and within that, our own submissions to our seniors for approval and the competencies can vary, and that can help you be a bit more flexible in how you approach the submissions, but can also be a little bit confusing if you're not sure exactly what's expected of you. But with those kind of things, my advice would just be to speak to your seniors about what kind of level of understanding they're expecting and what kind of level of submission they're expecting. They may well have had students before, and we'll be able to give you them as a signpost to speak with, so that you get a better gauge of what needs doing and you're not overworking and expecting too much of yourself, and at the same time you're not doing the bare minimum and then getting it returned to you for more information. So you can kind of do the one submission, do it well, and get it submitted faster that way. My journey. So I began at Barts actually as a cardiographer, performing ECGs, because I didn't have the relevant degree when I entered the field. So I was getting my practice in front of patients first, hands-on at that point, and learning some of the non-invasive cardiac diagnostic techniques like fitting and analysing Holter monitors, blood pressure monitors. From there is where I took the opportunity to get onto the STP programme, which took me the next 3 years. As I've already kind of mentioned, the brief overview is that the first year you spend doing the rotations and networking. The second year covers more non-invasive and invasive cardiology, so I spent more time in the catheter labs, which was very exciting at that point because it's completely new and introduced me to the world of multidisciplinary teams. As you're working directly then alongside your nurses, radiographers, doctors and so on. And in third year, I then chose to specialise in cardiac rhythm management. And then from here, I've now graduated from the SQ programme and have successfully got myself a position as a senior cardiac scientist, where I'm independent, working in the interventional cath labs, and independently seeing patients in the device clinic and some in France, and I am able to independently follow up patients in the remote service that we provide at Barts. So it kind of shows you where you can come from and where you can go through the STP and how it's helped me get where I am. This is my last slide to bring it all together and link it up to the idea of this toolkit. Doing this kind of course gives you the scientific backbone that you need to underpin this whole field, so you're really getting the foundation knowledge nailed at the beginning, and you can build on that as you progress and as you develop your career. It gives you the clinical skills, that increased interpersonal skills and teamwork, things like good communication, both written and oral, knowing how to delegate, and those kind of more personal skills are developed quite early in the career. Practical skills, actually how to do things like setting up pressure bags in the cath labs and putting into practice those skills that you're learning at university, but you're actually able to do them on site. Interpretation skills with clinical context. So for me, that really heavily involves decision making, and I find that a lot in this field. is how you interpret the information you get. It's not just about understanding what it shows you, but now knowing what to do with that information going forward and what the next steps might be, and how to deal with patients. So that might be confidence speaking with patients, things like showing compassion and care, making them, putting them at ease, showing them respect. And those skills, again, you learn from the first year of the course. And independence and confidence, overall, it becomes a bit of a whirlwind 3 years once you come out the other side of it. But the part of my toolkit that I've developed is having done it on my own and try to take it where I want and make the most out of it. I come out a bit more of an independent, a bit more confident in my clinical ability, and that those skills on the slide I'll take forward and develop for probably the rest of my career in one way or another. And that is a bit of a whirlwind stop tour, well, yeah, whichever word I'm thinking of, whistle stop tour of the STP and my journey on it. Thank you.
Thank you very much, Shahini. That you can have a whirlwind stop tour if you want. And in the interest of time, because we're a little bit late, we'll run straight on to segue nicely into Amy's presentation, which is on equivalence at STP level. And Amy's going to talk to us briefly about her experiences there. Thank you, Amy.
Thanks, James. I'll just share my screen. Hopefully it's just loading. There we go. So good afternoon. My name is Amy and I am a chief cardiac physiologist currently working at St Barts Hospital. Thank you very much to the BHRS for asking me to talk today. I'm going to cover a quick overview. What is equivalence? Well, it's an approved education programme in which the Academy of Healthcare Science reviews submitted evidence of knowledge, skill, competence in relation to qualifications and experience against the HSST standards and learning outcomes contained in the National School of Healthcare Science curriculum. So to apply for equivalency, there's no need for any existing master's level qualification, nor is there a specific length of training required, job title or banding. So for example, I started the process just shy of 3 years after completing the PTP programme. It's important to note that there have been a few changes to the portfolio and good scientific practice mapping document since April 2021, and these changes have actually made the process easier. So there is now greater clarity about the purpose of standards and how these relate to different parts of the workforce, as well as the addition of more side headings for and a reduction in the number of standards from 90 to 64 and removal of duplicated standards. So some of you attending today may be wondering why you should undertake STP equivalency. Well, there are lots of reasons, and certainly some of the reasons I wasn't aware of when starting the process myself. I previously had always felt that the purpose of completing equivalency was due to it being a necessary stepping stone for the HSST scheme. However, upon researching, there are a number of other reasons which apply to myself. So these included eligibility to apply for appropriate registration, that either being under AHCS or HCPC, and sometimes this is in fact necessary for some senior management roles or national healthcare science roles. It also offers a pathway to advanced scientist roles and scientist-led clinics, which, coupled with the ability to complete patient group directions and supplementary prescribing, promotes common standards for healthcare science practice. It also promotes patient safety, as well as quality assured and efficient patient care. So how to obtain? So this is broken down into 4 steps. So firstly, the application. So you need to register to join the Academy network. And once you have created an account, you will have 6 months to submit your portfolio. Step 2, at this stage, the portfolio will be assessed by a panel of reviewers and you will be notified of the outcome. Stage 3, now this is where the interview takes place, and this is usually done via video conferencing, and you will be again assessed by 3 assessors, 2 of which are professional and 1 lay assessor. The 4th and final stage is when notification will be sent to the HCPC of the outcome, and if successful, you will receive your certificate. So my experience so far, so the portfolio encompasses the largest proportion of the process. For my portfolio, I have included a summary of relevant training and experiences, my past and present research, and any list of relevant publications. and audits and service development projects. So whilst completing it is key, I always made reference to the good scientific practice domains, ensuring I evidenced my experiences to make the completion of the good scientific practice mapping document easier. Now, there are 5 domains. So the first, professional practice, scientific practice, clinical practice, research development and innovation, and clinical leadership. So whilst completing, I found that my toolkit wasn't quite as strong for the 5th domain, clinical leadership. So to further myself under this domain, I sought out opportunities to become a mentor, conducting appraisals, and have recently written a departmental SOP. And as we have learnt already today, there are a number of courses within the NHS that we can apply for, especially when introducing ourselves to leadership in healthcare science. So my advice, so if you're thinking of applying to complete the STP equivalency, my advice would be to start collecting evidence now, whether that's emails of conversations between MDT, whether it's scientific reports, or whether it's posters that you've presented at conferences. Collating a folder of these things is really useful. I also highly recommend engaging with any colleagues who have completed the process, and also if they have, maybe sharing examples of evidence of which they've used in their portfolio, and also visiting the HSST and the clinical scientist websites, as these have a wealth of information available, including frequently asked questions and useful PDF documents. So thank you very much for listening. That was a very quick whistle-stop tour of STP equivalency.
Thank you, Amy, and you again highlight the importance of the different aspects of the toolkit that for a process such as equivalence is something that you must really think about and spell it out for as part of that process, isn't that? So we'll thank you very much for talking and overcoming the technical issues as well. Well done. So we've got a special guest quickly. I think Stuart Allen is here and he's going to jump in with at this point. Stuart's principal clinical scientist at Manchester Heart Centre, I believe. So Stuart, are you there?
I'm there. Yeah, I'll start my video. So, and I'll just come out of here just to share my screen. Hold on. Find my PowerPoint. There we go. Right. I presume you can all see that, can we?
Yeah, looks good.
Perfect. So I've just sort of hijacked, thank you, James and everyone, because I've just kind of hijacked 5 minutes because I sit on a group called the Shelford Group, which is basically where all the organisational lead scientists from the UK meet, obviously virtually every 3 months, to discuss issues which affect us all as healthcare scientists. We actually spent the first hour talking to NHS suppliers who want to create a national uniform for healthcare scientists until she realised that there were 52 specialities within healthcare scientists. So sometimes there are mundane things like that discussed. But one of the other things that was also discussed, and I'm pretty much the only physiologist representative, was a recent survey that was done by the University of Birmingham, commissioned by the NHS. There was about 2,000, I believe, so not quite that much, about 1,000 respondents to a survey, particularly looking at grading post STP qualification. And physiological sciences does worse compared to all of the other. Now, within physiological sciences, of course, you've got cardiology, vascular, neurology, and respiratory. And with the risk of upsetting some of my colleagues in physiology, in other physiology sciences, cardiology and vascular did that informally better than some of the others. So the other specialities. And I said, well, historically, probably the work that's done perhaps in sleep or respiratory has probably been traditionally only been done at band 6 level. So trying to create it's at a band 7, and this could go into how, you know, STPs can change the world. You know, you can bring research in and make those roles much more expansive. But at the moment, now, one of the reasons for this, I think, was historically, certainly I still find that there are people who do their STP don't do their accreditation exam while they're an STP. Now, all the STPs that have come through Manchester have always done their exam as within their STP, so that partly because if there's no job for them at the end of 3 years, they've already partly can show that they've already started their accreditation. Now, historically, certainly I can only speak for BHRS accreditation, so I'm the chair of the BHRS exam committee, and one of the things I wanted to do was try and improve the speed of accreditation. So historically, if you were an STP, you might have to do the exam and then do your logbook. You could be looking at 3 years, and all this is all done looking at 3 years. So the majority of people, certainly 60% of proportion, are still at band 6 at 3 years. Now, again, I can only speak for the people that I know, but now, well, certainly across BHRS, the average time from the time of sitting your exam to completion of your logbook is now less than 6 months. So the 2 STPs that I have that qualified in September have now just been upgraded to band 7 as part of receiving their accreditation. Now, I know that's not historical, and it's perhaps just more of a point to see what happens in different centres. I mean, let's listen to some of the talks today. I think we do need to take the bull by its horns a little bit when it comes to our career progression. We've seen great talks about, you know, research and clinical examination and taking ownership of your clinics. And, you know, we're going to hear a great talk next by, you know, about when you've sort of done your HSST. But actually, and I think that physiological sciences has probably been traditionally the poor cousin to most of the other established sciences, and I think that we've got to change that by making ourselves more academic. And it's great. Part of the reason for asking someone like James to chair is that someone, you know, he's a physiologist, and, you know, he has a big standing in the research world. Historically, I think that cardiac physiologists are not very well published, and I think, you know, improving our academia is certainly a way to improving our grading over time. But yeah, I just thought it was interesting to show. I can get the link shared out to everyone so they can have a look. It doesn't drill down in the paper to the different physiological sciences. That was only done informally. But I suspect that the majority of the physiological sciences still at band 6 were probably not cardiac, but there were still a significant amount that was still at band 6 after 3 years. And I don't know if that's a fault of the centre, a fault of the STP themselves, or just a mixture of both, plus the fact that it can be quite slow to achieve band 7s or band 8s because of traditionally what people perceive those roles should be. But hopefully, as people come through that are more academic and want to change the way that we do things as physiologists, then people could be upgraded or at least be given the appropriate grades can be looked into a business case, so that we can expand the role of physiologists out of the traditional role, and that would therefore become higher grades. I think that's all I really wanted to say, James. It was just to sort of highlight that I think that all the great speakers that we've got today really should be shifting this curve from people being traditionally at a band 6 for 4 or 5 years, waiting for a band 7. Well, it's not about waiting for a band 7. It's about saying, well, look, I'm bright enough, and you know what, and I've got good ideas. What can we do to put a business case together, do research, and change the role? And look, these things don't happen overnight, but often these things, physiologists can't wait for it to be spoon fed to you. You've got to get out there and do it yourself. That was it.
Completely agree. Thank you. Thanks, Stuart. No, and I think if there's precedent, one of the things is if there's precedent out there, because the people looking at spreadsheets and holding bags of money, etc., want to know what does this mean for the department? What does it mean for the service? What does it mean for, and is this done anywhere else? Etc. What do these roles exist? So if we can say there's precedent and this is the fantastic work that's being done, these are the improved outcomes for waiting lists and patients.
Data is king, and you've got to have that data. Physiologists, again, traditionally are very poor at collecting data, very good at sort of saying how much they've done each month, but what does the outcome, what's the meaning of that data? And I think we've got to be much better at that in our department. It's got to really drill down to the granular level.
Lovely, thanks so much, Stuart.
No worries.
So we without further ado, we'll move on to our final speaker from Rotherham, who's Lucy Broadhurst, who's HSST graduate in cardiac science. And Lucy, if you're, I think, Stuart, you might need to stop sharing your screen, but Lucy, if you're there, you can hopefully share yours.
Brill, I'll just share my screen. I'm hoping we can all see this. So I shall start. So firstly, I just want to congratulate all the other speakers. I've really enjoyed listening to all their talks. I think they've been excellent. And thank you for inviting me to speak. See if it wants to progress. Okay, I'm having problems moving my slides, which is not great. I might just stop sharing. Apologies for this. I will try again. There we go. We're in business. So my name is Lucy Broadhurst. I'm a consultant clinical scientist at Rotherham, which is a district general hospital in South Yorkshire. And I'm going to talk today about HSST and my pathway to graduation, what happens next. So I actually started HSST in 2016 and I'm just graduating now. So I've passed everything and I'm just waiting for the magic piece of paper to drop through. So HSST is the Higher Specialist Scientist Training Programme. It's a 5-year professional doctorate. And as has already been described, you have taught university modules and work-based learning. You also have a large research project to do, which is 40 to 50,000 word thesis. And the research project takes probably the last 2 years of the 5. You also have to develop clinical skills in accordance with a good scientific practice framework. And it's exactly the same framework as you've just seen for STP equivalence. And you have to develop a portfolio of evidence to prove that you're working across the 5 domains. And then you have to defend your portfolio in front of a panel as part of the IAPS, which is the Independent Assessment of Professional Skills. Now, HSST is bespoke training. So the type of training activities you'll do as part of your work-based learning is completely due to the needs of your hospital and what the niche is for developing towards a consultant clinical scientist within your hospital. So it could be very different between one HSST candidate at one hospital and another. And as we've already discussed with the Physiologist Toolkit, the idea now is to push yourself away from the traditional physiologist role. So HSST does push you out of your comfort zone. You're taking on roles which are traditionally done potentially by doctors or other professionals. And we've already discussed HSST is funded by Health Education England, and your hospital will be expected to develop a consultant scientist position at the end of HSST. That's part of the agreement with the funding. So what's involved in HSST? What have I been up to in the last sort of 5-6 years? Well, firstly, you do a lot of work on leadership and service improvement. So the first 2 years of HSST, when you're doing most of your taught modules, a lot of that is around leadership. So you learn about yourself as a leader, what type of leader are you, how to manage other people, how to motivate other people. You learn about change management. And then you also learn lots of practical tools, such as how can you get innovation, how can you get research actually into practice, how can you embed it as part of your practice, and quality improvement tools. So it really does give you lots of skills that you can bring into your day-to-day work. Of course, you're also going to develop your clinical expertise, and you will do that as part of your work-based learning. You do have modules on that at university, but most of your actual practice is back in your own hospital. So this is all your advanced communication skills, it's your history taking, and it's your clinical examination. So to develop those skills, I was out shadowing my consultants. I went following our community heart failure nurses. My specialism is syncope, so I went to look at different syncopes throughout the UK. So I've done quite a lot of things to try and improve my clinical expertise. Now, also, there's a large research component. I've already said it's about a roughly 2-year research project. And you are expected to take that all the way through. So this is coming up with the idea, writing a proposal, looking into funding. If you need funding, you can actually use part of the HSST bursary towards your research, to fund your research, and then taking it through ethics, managing it, writing it up, and hopefully publishing at the end. And I don't know if you can see on screen or whether it's being covered, but there's a lot of presenting involved in HSST. So there's a lot of presenting at university, but you're also expected on HSST to get out there, to network, to promote healthcare science. So you are expected to, get involved with HRC, get involved with the professional body, and other opportunities to shout about what we do and try and raise the profile of our work. So life after HSST, what's it led to? So I've recently gone into a consultant clinical scientist position. I have a 50% clinical workload. And as part of being a consultant, I obviously have greater autonomy and greater accountability for my own work. So I have my own patients, my own caseload. In my own job, which is obviously specific to me, I've regained a strategic leadership for the department. So I'm still the cardiac physiology lead. The next step for me is to try and get my research project published, and I would like to keep pushing forward with research, and I do have that as a component in my job description. And I will also apply for the higher specialist scientist register when I'm available, when I'm eligible to that, once I've got my paperwork through. So what type of things do I do in clinic? What do I actually do? Well, as I've mentioned, my interest is in syncope. So I see 2 types of patients. I see syncope referrals, so patients referred to cardiology for assessment of their syncope. So I'll assess them, I will take their history, I'll examine them, I'll refer them for tests, I'll give them their test results, and I'll decide further management. And that may be referring for devices. For example, I'm very well supported by MDT, and this role is evolving. So I imagine what I'm doing now will change and move forward. I also see CRM patients. So I'm very involved in CRM and in devices. So those CRM patients, typically patients with problems, it could be lead problems, upgrades, downgrades, people who are referred for, they might be referred for suitability for ICD or CRT. That's the type of patients I'll see in clinic. And I also triage most of the device reports that come from our pacing clinics and our device clinics. And obviously you can see the benefits of this. We've already mentioned that physiologist-led clinics can improve waiting times. And it certainly does. So from a consultant scientist position, I share the workload with our cardiologists. It enables better use of resources. There is an MDT approach because different disciplines bring different skills, a different perspective. So it's great. And it's upskilling. So it's upskilling for me, but also that cascades down. And over time, this, clinical assessment is going to be a much greater part of every physiologist's role. So that's life after HSST. So top tips for HSST, in my opinion, is ensure you have protected study time and take it. So just like for the STP, HSST, you are supposed to have study time. Everybody I know who's doing HSST is quite senior in their department, and it's incredibly hard when you know there are workload challenges to take time out for your own personal study. So I found it very difficult to take study time, and that is the one biggest thing I would pass on to anybody else, is make sure you take it because it is essential. Also, ensure the MDT team are on board. So ensure your medics are on board and the nursing team, so that you can secure their time for your training. You don't want to be pushed to the bottom of the queue, because obviously the consultants have lots of doctors and other students coming through. You want to make sure that you've got their time as well. You need to sell it to all staff, sell it to the physiologists, sell it to everybody, so they all know exactly what to expect and what you're working towards. And then this is for the departments, for the managers, or you considering having a HSST in your department. You need to plan how a consultant scientist role is going to fit within your department. What is the job plan? What does it look like? And also with the grading. So everybody wants to know, I'm an 8C. That is in keeping with all the consultant scientist roles within our hospital. Consultant scientist positions are very well established, for example, in the labs. So you need to look at how that's going to fit in your department. And this is, again, for managers. You also need to ensure that the consultant scientist role remains within the workforce plan over the 5 years. 5 years is a long time in the NHS, and things change, people retire. You don't want the funding for that role to get lost over time. And the last thing is, I suppose, be prepared to adapt the job role as the profession and the department evolves. At the start of my HSST, I was not anticipating going down the syncope route, but that's where the greatest niche was within our department, and that became apparent over time, and that's led on to that for me, and it's great. So thank you for listening. I know that was super fast, but I'm very conscious of time. If anybody wants to email me any questions or get hold of me on Twitter, then my email address is there.
Thank you, Lucy, and thank you for talking, and congratulations on your consultant clinical science post. It's incredibly exciting. I can only imagine the work that went into your HSST, all the different aspects that you had to undertake, and it really is the pinnacle of all the things we've talked about, isn't it? All the elements of the toolkit. You can't afford to have any one of those lacking in your current role, and hence the HSST is geared up to teach. Correct me if I'm wrong, but the first couple of years are quite heavy on the leadership and side of things. So thank you very much for that. So let's I've got some questions for almost everyone, but I wonder if probably what we should do is work through as a panel. So if we're on to the panel discussion, if everyone wants to turn their video on, and we'll go through in chronological order, because I know time's really tight and it is Friday afternoon. So let's whisk through a couple. Okay. So the first question was from an anonymous member, a bit cloak and dagger, but it says, how do you manage? It's a really good question. How do you manage your time effectively when taking on more responsibility beyond your work? So that is that's something that affects all aspects of everything we talked about. So who wants to pick that one up first?
I don't mind taking that one. I've already alluded to that in my talk. I found time management really hard, and it was, you do have to be quite selfish to make sure that you dedicate some time to yourself to do this. But I would say also you need to be incredibly self-motivated and incredibly driven. Some of these courses are very challenging, and you've just got to prioritize what's next and work very hard. But I won't lie, there's always going to be an expectation to do some of this in your own time.
Yeah, I think I'll second what Lucy's saying there, really, because I'm doing exactly the same as you. With some of my study time for my PhD, I end up, well, at the moment, rearranging appointments. So yeah, I do spend time outside of work doing my PhD studies, but needs must, I suppose.
I think it's also important to say that whilst we've got to look at what you do currently in your roles, and like I said, you may be doing several things and using these elements from this toolkit that you're not even aware of when you're contributing to an SOP in the department, or leading on an SOP development, or helping design new services, or collecting some data for another person. You may not, or a colleague or an academic, you may not be aware that you're doing these things. So it doesn't necessarily need to be outside of your working hours. It's about looking and seeing if being savvy with your involvement and what you get engaged with, because there will be opportunities within your practice to develop the skills of this toolkit and develop your responsibilities. Good. Any other comments on that before we move on to the next one? In that case, I'll move on to a question from the audience. This is Tabo from South Africa, who comes in with another good question, which is, if I can find the chat, where are we? So Taba's from South Africa. It says, they say, I've found very few physiologists are on the academic route. And how does one encourage other physiologists to be more involved in academia? Leeann, you're an obvious place to start.
Yeah, I know. Thing is, it's always going to be difficult because not everybody enjoys research and going down that academic route. You can certainly try and foster that ethos, looking at audits, getting them involved in things that are going on within the department to see if actually this is something they'd be interested in. It may be that they've not had the opportunity and they need that to actually realise it's something they enjoy.
Yeah, 100%. It needs to be about offering lots of different opportunities and ways to get involved. You're not asking someone to write a grant application off the bat and have the crushing rejection of having it turned down afterwards. It's about offering them the ability to dip the toe in the water, have the satisfaction of maybe something from writing up a case study and doing a little bit of literature. That is getting involved in the academic process, literature searching, presenting other people's research, etc. Taking something from a service evaluation through to a conference. Those things are confidence boosting and really useful ways to spur an interest, aren't they?
I agree. I was just going to say that I completely agree with what Leeann said. I think it's really important to involve all the staff, junior members of the staff, in audits or creating SOPs for the department. And I think that is the starting point. And the more they do, the more they will be motivated in doing case studies, in publishing and presenting in conferences. So I think if we start with a little project, then they will be even more and more motivated. We currently do that with all our members of staff, junior members. And I think that has a very good outcome usually.
Thank you very much. The next question, I think it didn't come up in the Q&A, it came up in the chat, but I'll try and find it. I've written down a question from Jaya, which is, this is for our an STP type question. So can band 6s acquire STP directly without being a band 7? So I think one assumes that means STP equivalence, because you wouldn't necessarily go into the STP program as a band 6. If you were anything above a band 6, because it is paid at band 6. So one assumes that means, can you get STP equivalence without being a band 7? I would say absolutely yes. It depends on experience and qualifications to a certain extent, but if you can meet the domains and the standards contained therein, which are, as Amy alluded to, have been simplified thankfully last year, then absolutely. Has anyone else got any comments on that?
I think it's an evidence-based process, isn't it? So as long as you can evidence it that you meet all the criteria within the domains, I think once you're happy that you'll satisfy that portfolio requirement, I think go for it.
Yeah, 100%. And like so many aspects of what we're talking about today, it's about looking at precedent. So if you I think quite a few departments across the country are lucky enough to have people who've gone, one or two people who've gone through the equivalence process now. We're not reinventing the wheel. It is not a secret society that needs to be kept. You need to have a particular tattoo or something. We want to share knowledge and keep pulling people up behind us, up the ladder as we do these extra bits. So find the person who's done it. Find that there's resources available. The Academy of Healthcare Science being an obvious place to start. Websites such as the Clinical Scientist, who can put you in touch with colleagues across the country and the nation who've done this kind of thing and offer mentorship. So yes, that's the way to do it. Good. Let's look at another question. Sanam has asked a question direct for Shahini, which is, what advice would you give to current STPs? That's a big question.
That is a big question. My maybe main takeaway would be to be proactive as a student and take up all the opportunities available to you. And that includes the ones that are a little bit out of your comfort zone, because it's the perfect time to kind of hone the skills, practice, learn from those around you, ask questions. And if you're going to make mistakes at any time, it's a safe way to make those mistakes and learn from them while you're a student. So I would say my main advice would be to like really put yourself forward for those 3 years in making the most out of the course that you can where you are.
Thanks, Shahini. And I can see in the chat, this is showing my Zoom naivety, but in the chat it says Steve Sadler would like to answer this question live. I don't know who Steve Sadler is, but Steve, if you can answer live, then do. It may be that we need to make it so you can be unmuted. While we're thinking about how to do that, let's have another question. I was thinking whilst in one of the earlier talks how Anna, your talk on clinical assessment and history taking, that really, I know there's an element of it taught in the undergraduate degree, but really you could make an argument that every physiologist should revisit clinical assessment and history taking, no matter what path they take and what role. What are your thoughts on that?
I couldn't agree more, to be honest. I think, for example, when I did this training, I did my graduation in 2007. So a lot of the knowledge, of course you build up, but some skills like this, I think you definitely need some training. And I think in every role that we have nowadays, as a clinical scientist, as a cardiac physiologist, you do need to understand how to assess a patient, at least how to take a patient history, because otherwise, how are you going to see the patient as in a holistic way? Like we shouldn't see the patient in a separate way. So we are, for example, in a device clinic, but we cannot just look at the device check. We should see our patients in their whole composition and see how we can actually assess and treat the patient in the best manner. So I truly agree that these kind of skills should be part of each physiologist nowadays, to be honest. I do think it's a good skill, definitely.
And your department's done fabulously well to get 7 physiologists through that master's program. It's almost like we need a not quite a PG cert, but a development day that's targeted on cardiorespiratory assessment and one on history taking as well. That would be fantastic.
Yeah.
Perfect. Okay, next question. We've got I had another one that came through whilst Lucy was talking, and that was thinking, Lucy, you talked indicated the fact that part of the HSST is about going out there, promoting cardiac science, healthcare science in general as well. In the pandemic and the post-pandemic world, obviously we've had no work experience students, as I'm sure that anyone else has. I haven't been able to do several of the visits I wanted to do to different centres. How can we continue to promote cardiac science, healthcare science, and these skills while we're in a pandemic / post-pandemic world?
It has been really hard, hasn't it? I mean, COVID's changed everything, but I think, let's be honest, the forum that we're on at the minute is the perfect way. So virtual, you can do it virtually. For example, we recently had an STP open day, which obviously in an ideal world would have been face-to-face, and at the last minute we decided it would have to go virtually. But you can do that, and you can do that at whatever level, and I do think that's the way. We need to get out there. We need to offer this type of virtual forum to promote and it could be any level. It could be the apprenticeships, it could be anything. because we do need to engage, and I think we perhaps also need to start going in at college level and going in at schools to raise the profile of our profession. People don't come out of school and think I'm going to be a healthcare scientist, do they? No one says that to their dad. And I think we need to change that. They don't even know about our profession, and we've got a big responsibility, I think, to get out there and tell people who we are and what we do, because it's a great career. It is a great career.
Yeah, 100%. And I think we're doing a lot of schools, reach out program. Again, it's virtual, and it can be. I think I'd much rather stand up in front of an assembly full of children rather than do it virtually, because it's, you have the same issues that we've all had on Zoom or whatever. But if you can actually see faces, it's far more reassuring, isn't it? And people can probably feel more confident to ask questions. But yes, it's a temporary measure and a half decent one to do online. Fantastic. I'll quickly come back to the questions from the chat, because I'm asking too many myself. So this one from Dylan Coles. So for Shahini, this is exactly following on from what I've said there. How did you find work experience for your application? I'm currently finding it very hard to find work experience due to COVID. This is a tough one.
I was going to say, I'm not sure I'm going to be able to shed much light on it, because when I applied, it was pre-COVID times. And hopefully with things going back to normal, there might be departments beginning to open up to work experience students, even if that's a day or an afternoon or a morning. It's still all valuable experience, definitely. Engaging with these kind of things is great, because it shows that you've got an awareness of what the profession holds, even what the profession's future might hold. And I'm sure that'll make for really good interview material or application material when you get there. The other thing that you can do is also engaging in some of the social media platforms that are out there, because there's a whole group of people that are all talking about what it is to be on the STP. So one of my colleagues is heading up the STP Buddies social media page, and they always bring out webinars where you can talk to people that are already on the course as well, see what they do in their day-to-day, ask them what they think is required, and kind of you can start networking even before applying. Just to increase your own awareness and give yourself a good place to stand. And I think that's probably how I would approach it if I was applying now, because like you said, it might be hard to get in hospitals, but I might have to kind of think a bit more creatively about how you can get the experience and knowledge in other ways. I don't know if anyone else has any other ideas.
I think the social media things are definitely a good shout. That goes back to promoting the career in general. And also for Dylan to sort of engage with current trainees and sort of get an idea and a feel for what's involved. I think trust will start to open up a little bit more now. The regulations for the general population have changed, but we'll just have to play that by ear. But don't give up, Dylan, just keep trying.
Yeah, that's completely. And what I've spoken to many people and had people visit who are making STP applications before, just sort of had a coffee or whatever. We can't even really do that, have people who don't work at the hospital coming in at the moment. So, but it may be possible to do a phone call, maybe there may be times for a quick chat, which can say, you can put on your application that you've reached out to various people in leadership positions or whatever, that can bolster your CV and application, we hope. Okay, good. Next question. I realise it's 5 o'clock now, so I'm really keen to wrap up very soon, but from Eleanor McGahey, we've got what keeps your passion for learning and working in science alive when working under a lot of pressure? Who wants to take that one?
I'll take that one. I would say that we're all human. So, we are going to find times when things are a little bit stressful, depending on what you're sort of specialising or advancing in. You've alluded to grant applications being rejected. There's days that are tougher than others for all of us in the profession. But I think sometimes when you have even just small wins, a good day at work, a patient that you've helped, Lucy finishing off her HSST and getting to that point of graduation, finally having that bit of paper in her hand, they're the sort of things that are going to bolster your sort of motivation and keep your passion alive for working in science. But be kind to yourself and be kind to your colleagues as you're going along, and that's going to keep us all going when we're faced with immense pressure, really, and keep our passion alive, hopefully.
I would definitely agree with Amy on that one. I've had a pretty tough week this week, and only yesterday I just had a patient that I just had a one-on-one chat with as I was taking the ECG leads off, and they were just so grateful for the work that we do. And I think it's sometimes easy to forget when you're kind of so in an academic mind that actually the people that matter most are your patients, and I would definitely say they get you through the day. So just keep going. Yeah.
Thank you, Sam. And Amy, yeah, very important points to keep your head above. It's okay. It's also okay to say that you're struggling with stuff and there are wonderful services available throughout trusts with wellbeing services, and it's you know, it's really important to talk to colleagues and a professional who's not, if needed, and who's not directly, you know, involved in your circle of work. I can absolutely advocate for that. So in the interest of time, I think we've got perhaps one more question, but then I was thinking that we should probably wrap up after that, guys, if everyone's in agreement with that, because it's getting on. So let's just, I think we've got one more question. There we go. James Batty, am I saying that right? How did you get senior management engaged with how our roles are developing and advancing within the workforce management? WFM, is that workforce management?
Yeah, it is. I mean, what I would say with this is certainly for roles in our department, we've done clinical audit. So particularly for, say, our syncope service, we did clinical audit to show what the benefits will be and how it will improve resource use. And that's how we did. As soon as you present that to clinical, to senior management, they'll soon see the benefits if they can see how it can improve pathways. So that's the route we took, and it was quite effective.
I think for me going forward with a PhD, I was very lucky. My general manager was incredibly supportive, as were all the consultants. My initial stumbling block was actually my departmental manager, but we eventually got through that barrier, and I continued on. But it's having that support, and I think sometimes having the consultants on board can really help.
Absolutely crucial. Fantastic. In the interest of time, guys, I think it's 3 minutes past 5. We should probably wrap up on a Friday afternoon. Thank you so much to all of our speakers. You all did a fantastic job putting talks together, and with a really short turnaround as well. So thank you very much for your contributions. Thanks to the BHRS for hosting the webinar. I'll close by just sort of a couple of reflections on our toolkit, which is that, you know, the NHS was probably under a process of change and new ways of working before the pandemic, and that it is absolutely true to say that it's changed now with new pressures, new challenges, and very importantly, new opportunities for people to work, you know, pushing the boundaries, working at the top of their license in all areas with positive change. So, you know, these tools that we've talked about, the aspects of leadership, teamwork, teaching, academia, clinical assessment and expertise, and a sort of holistic knowledge of the pathway, focusing not on the test but on the pathway and the condition itself, will be crucial moving forward. So I really implore this can't underline the importance of this toolkit enough. So thank you very much for coming and taking part, and have a great weekend.